Okay, we're going to go ahead and start our Ask the Experts session. As you can see, we have several ALD experts on the stage. This is an opportunity to ask them anything about ALD. So, who wants to start? Who has a question?
Gene, you referenced the gene revolution, I think you said. The fact that we're going to be able to revolutionize disease because of gene therapy of any kind. Can you comment on that?
Sorry, myself?
Yeah.
Yeah, oh, sorry. The future of gene therapy, or how you think of sort of a path forward. Well, I think one thing that actually Patty could talk about is the whole wave of gene editing that's coming our way, and how she is thinking of scaling that up and how to make that available, as we think of this as sort of the next generation of more personalized treatment. But it does require sort of thinking about individual genes and how to correct them, but there are also opportunities to do this maybe in bulk.
So the major challenge of these new technologies that you've been hearing about, CRISPR, these enzymes that can go to your DNA and change one letter. And for most patients with ALD, there is one letter that is changed. For others, there is a little deletion in the gene. And these enzymes can do both, can just change the letter back to normal, or they can insert the part that you're missing. In the future, potentially, they can insert the same gene. You heard David Williams talking about how we can put the gene where it belongs, not randomly in the genome of a cell, and that would allow it to be regulated the way that it's normally regulated. So the technology to do this in cells in the dish is happening. There are patients being dosed with cells that have been edited in the dish every day. So one of the examples is CAR-T. It's a therapy that is for cancer, and there are cells that are being trained. You change the DNA of the cell to go and attack the tumor more specifically. There is also patients that have been dosed at NIH. Dr. Glenn Stiver, who had the posters up there, has been the person developing the enzymes to treat immunodeficiencies. So you take the cells of the patient, change the gene back to normal, and then put the cells of the patient back into the patient with a bone marrow transplant style that we do also for gene therapy in ALD. So the technology is now there and able to do a lot of things in cells. If we're not doing the classic ex vivo, like gene therapy, like Skysona, still requires chemotherapy, getting your cells, changing them in the dish, and chemotherapy and putting them back, the biggest challenge is to deliver these enzymes to the cells that need to be corrected in the body of the person. So going from the in vitro, the dish, to the in vivo, this is the challenge that everybody is trying to work on. And there are two advancements that are happening, and we are going to be seeing patient data, not in ALD, in other diseases. One is the AAVs. These are viruses that can get to the brain and the spinal cord. They have been improved, so you can lower the dose and have less side effects. Those novel new vectors are going to be reading out clinical data in the next 2 years, and they will tell us, are they safe? Are they getting to the brain? Are they getting to the spinal cord? In different diseases, but I think we're going to see that data that is going to inform, can we use these ones to put back ABCD1 in the spinal cord and the brain? And then our challenge as a community is when do we have to do this that is early enough that we can change the trajectory of the disease, that we can prevent the onset of symptoms, or that we can halt the progression of the disease. That's a much bigger challenge. And then the other advancement that has just recently happened is that you have this lipid, they're like kind of fat bubbles that can encapsulate these enzymes, and you can put them in the body and they can go to places. So you've heard probably Baby CHOP. UBKJ is an infant that was treated at CHOP last May. Well, he was treated from October to May with these LNPs, lipid nanoparticles, with the enzyme that edits your DNA. And his defect was in the liver, so easy, because the liver is easy to target. And they were able to correct his mutation and kind of like make the disease that he has much, much better. He has hyperammonemia, it's a metabolic disease, and he's doing great. But that's the first baby ever dosed with a genome editing in vivo. There have been adult patients, many, more than 400, treated with genome editing in the liver. So what is happening now recently is that these LNPs are getting better at going to somewhere else than the liver. For ALD, we need to correct the adrenal gland, the brain, the spinal cord. And those are more harder to get in by definition with anything that we want to deliver. But this technology development is taking place. And one of them, to get to the stem cells in the bone marrow, may be happening in the next 2 to 3 years. I think we're going to see them again in a different disease, and we're going to learn if they work. And then we are getting ready, trying to have the editing ready to be able to use those tools. But the limitation right now, if we're going to go the route of bone marrow transplant, we are there. We can do a lot of these things. And scaling them up is going to be a challenge, but the technology is also being developed to...
You have to check in with what people are
Yeah.
hearing and,
What?
and asking, because there's a lot of jargon and people might not understand.
Okay, we have another question.
Oh,
Or you
was
guys
not the
can tell
question.
me.
Maybe I was waving
Yeah.
to Michael.
Oh, sorry. All right, never mind. Anyone else who has questions?
So I'm very new to the ALD research space, and I learned an insane amount yesterday. But I get the sense, and correct me if I'm wrong, that there seems to be a lot of research being done in imaging techniques, whether it's imaging microvascular changes or this iron imaging or spectroscopy, where I'm coming from, where like it is established that there is signal to be measured that is informative about ALD, at least in a correlative fashion. So how do you think about adding these modalities and these techniques to your research programs and eventually maybe standard of care to find out whether there is prognostic information, diagnostic information, predictive value in these things where it's clear that there's some signal and it might be very useful, but you don't know unless this research is being done?
Eric, from the research to clinical.
Is this one on? So good. Keep it simple. Good. It's a good question. The answer is yes and all the above. I think we produced the standard of care guidelines for surveillance for cerebral ALD now more than half a decade ago. A lot of real-world information has come from that. There is an international effort, so I'm talking clinical at this point. There's an international effort to standardize what MR sequences we use to do screening and then also to do lesion monitoring. That work is submitted and currently under review with a journal. So that should hopefully come out in the next 2 months. So you'll see that pop up. A lot of people sat around the table and thought really hard about what we're trying to do at a clinical level. From a research perspective, in that paper, there's going to be recommendations about what has data behind it so far in the research, in the imaging world, and what it can potentially tell us. But we're very clear about the fact that it's still research. Getting it fully translated to something that's fully predictive is a large undertaking, in any of these things, diffusion, QSM, perfusion. But practically, one of the ways we do it is for the patients that we scan, if you're part of an institution that has a research program and some funding, is we enroll patients into one or a couple of our IRB protocols that have imaging as a piece of it, and we can tack on those sequences because we're scanning the patients anyway for clinical measure. So my team's heard me say this a lot. I live in clinical research, and there's this sort of middle ground where you're sort of doing both. And thankfully, what I found in this community is people are quite supportive of that, especially the patients. So it's a good partnership that we have with our families. Does that answer the question? Yeah.
Okay, we have an online question. My son had a bone marrow transplant and now has AMN. What is known about other boys a long ways out? Is this expected with boys who are transplanted?
Yeah, I think the dogmatic answer is that transplant does not protect somebody from AMN. So, because it's a bit of a different pathology, and the transplant doesn't necessarily reach the peripheral nerves, that we could never say that. Hasn't been formally studied? No, it hasn't been yet. We've isolated enough boys that are old enough to do it. There's probably 40 to 60 now, but we'd have to do it across the whole country. Anecdotally, I think we all have patients, I know Florian has patients as well, that have had transplants and have had some AMN signs.
Yeah, I was actually just talking with Mitch about this as well. These boys now being young men and wondering about some of the symptoms. And I think it's a hard question to answer because obviously you've gone through treatment of a brain disease that has left some residual scar, and the tissue might not only be prone to getting AMN, but also suffering some of the sequela from past lesion or chemo. So, but in any case, what's important is to bring that population together, study that population, and do the best that we can help prognosticate for them, regardless of whether it's AMN or not.
Questions in the room?
I'm an AMN patient of Dr. Eichler's. How would one find out about such things as an autopsy protocol for information that would be useful to researchers or about brain donation?
You can come and talk to your doctor. But thanks for bringing that up, and it's actually it is of importance, and so thanks for raising that. It is often something, yes, we do not, as physicians, mention to our patients, but we certainly, as patients come to us and are interested in that legacy that they might provide for the field, that's very important to us, and it is important, data that all of us here value and cherish and pushes the field forward.
Yeah, so just to add on to that, there's the NIH Brain Neurobank, I think that's what it's called. I might get the title slightly wrong, but something along that line, where you can actually go online as a living individual and sign up there so that they are prepared in advance, and then they will arrange, and they give sort of instructions to that process as it then happens, to ensure that when the autopsy is happening, that brain material is transported. And then that brain bank has been around for many, many years, decades. In fact, it's been a source of autopsy material for all of our labs. So it's a great resource. And despite the fact that many people have done that, it's still a very small bank, and it would greatly benefit from more samples. And having that in preparation is helpful, because then they can communicate with the pathology department so that when it does happen, it is done correctly to not lose any tissue due to degradation, if there's a delay and the processing is not done right.
Hi. So I have a question about, I guess I could say maybe supplements or other things that patients might try that have not been obviously proven to be effective in phase 3 studies. So patients do and will continue to bat around ideas amongst themselves, things that they want to try, things that they have tried. And I know as doctors, you often can't really give any opinion on those, but they do range from, for example, antioxidant cocktail, which might have a little more support for it, NAD plus precursors. Then there's other things like peptides and people going to other countries to try what's called stem cell, some sort of stem cell treatments. Given that I understand you can't really recommend any of them, how, as patients, can we tell whether any of those have little support, no support, or a medium amount of support? Is there any guidance you can give short of an actual recommendation that you can make based on evidentiary phase 3 studies, which we probably won't have for supplements?
I will just start, and I know everybody has an opinion about it. But I think one category that should be added is potential harm. You didn't mention that, right? So there is one thing to say, let's discuss potential benefits, but I think also critically potential harm, and especially when it comes to stem cell tourism, when we have no idea what kind of stem cells people get when they go to these clinics. The route of injections are often invasive. And the potential for severe, significant adverse events that have been reported, like a tumor as a potential risk factor when you get cells injected into your body that grow out of control, infections, and worsening symptoms are certainly a thing. When the first stem cell trials on the formal trials setting up started in Parkinson's disease, where they were injecting dopaminergic neurons into the brain of patients. The very initial studies looked promising because it was like a 2 case and the patient became better. And then as the trials became more systemic, it actually turned out that they were having adverse events in that treatment group more likely than in the untreated group. So it was causing more harm than good. So I think that's always to be considered in the equation. And so a lot of things that are out there are potentially benign, but there also are things that do have significant side effects, even when it comes to supplements. For example, like very recently there was a release that a bunch of supplements people take include high levels of lead in, I think, protein powder containing high levels of toxic levels of lead, so you have to be careful about that. The most important thing is though also that supplements are not regulated in the United States by the FDA. So when you buy 5 milligrams of melatonin, it may be that it has 5 milligrams, but there are also third-party people who check and say it's 0.05. They found like hundreds of the dose that was claimed, or sometimes 20 times higher than the dose. And these are things that are challenging when you don't study. I would just say melatonin is a great example. Melatonin, a lot of people probably in this room use melatonin. We have always thought about as a nice, benign thing, doesn't do much, may help with your sleep. There's a study that was very recently published a week ago showing that people who take melatonin are 83% high risk of cardiovascular events than people who don't take melatonin. So for insomnia. So I mean, it does have side effects. Like that's you don't see that until you do large studies. That's the challenge. But I'm not going to comment about special.
To answer more proactively, what kinds of things are maybe good, would most of us recommend or be okay with? I recommend focusing on diet and lifestyle for a couple reasons. One, rather than focusing on supplements or exotic treatments, diet and lifestyle have been shown to impact longevity, general health, mental health in just about every setting. They play some role. I would look at that as being true here. For people with AMN and ALD. The diet and lifestyle that most of us would probably endorse is probably not a surprising one, but the diet would probably be a Mediterranean-like diet. That's whole foods, mostly plants, not a lot of red meat, saturated fat, not a lot of alcohol. So that's the that's the diet that has been most widely studied, and we don't know if it really matters for ALD, AMN, but my wager, a safe bet, is that it matters to some extent. It's a matter of how much. So I would focus on that, staying active, being socially engaged. Those are the things that actually are probably most generalizable, and those are drawn from just a broad literature of what is good for human health, what is good for human wellness and happiness and other things. I think that's a good place to start. If you want to try supplements, I would say maybe limit yourself to 2, 3 max, no more. And I wouldn't hazard a great bet on what might be most useful. I mean, our lab has studied vitamin D supplementation. I do think that avoiding deficiencies in all nutrients matters, so you want to have the right sufficient mix of just basic nutrients, but I recommend getting that from your diet. And a good diverse diet is a good place to start.
Yeah, maybe I'll just cap this off by saying, we hear you. This is of interest in the community. And if I think of what's happened in the ALS community, they actually have a whole website called ALS Untangled, where they take the various drugs, supplements that the patient community is interested in, and then depending on the number of inquiries, they rank these, and then they get experts to review evidence to date, and that might be something that we could do if it rises sort of to that level of interest. So just to tell you, we hear you. Yep.
Okay, Felicity has a question from online.
There's an online question. If we gain the ability to knock out the ELOV1 gene in an embryo that has a pathogenic ABCD1 variant, could that lead to a baby that could have a healthy life despite that pathogenic ABCD1 variant?
That's an excellent question. And the short answer is it's not a good idea to knock out the ELOV1 gene. There's actually, people have made a mouse model, a knockout mouse. So that means that there is no protein left. And that mouse dies at day 1 after birth because the ELOV1 gene is very important. Is very important for barrier function. So it's highly active in your skin, in your lung epithelium. So because you need a water barrier, otherwise we dehydrate. And this mouse doesn't live longer than 1 day. So that's the short answer. Knocking out is not a good idea.
Yes. Okay. So you're saying don't do it.
Don't do it. Yeah, don't do it. Knocking out.
Sorry.
As we gain more data, specifically from newborn screening families, obviously we're having a lot of families identified that don't have any prior symptoms that have potentially been passed down for generations. Do you find that you're seeing women who are younger than what we currently have as like the general age for symptoms to potentially set in? Do we see women with symptoms earlier, younger? What is that standard of when we would, quote unquote, expect to see symptoms? Is that getting earlier?
Yeah, that's a really good question. I mean, I think through more families and more women presenting through newborn screening, we're going to sort of rapidly catch up. I think the numbers are just probably not very accurate in terms of the frequency of different gait symptoms or bowel and bladder symptoms and things for women like starting in their 20s. We're not looking earlier than that, but we know that for men, typically the symptom, the spinal cord symptom onset isn't until the 20s typically. There's some really nice papers. Sometimes I highlight in my talks, but I didn't yesterday. By Wolfgang Kohler's group in Leipzig. There's a neuropsychologist actually who's done some really nice focus on women and looking by age groups. at the symptoms that they report most frequently, and sort of breaking that down into like pain symptoms, gait and balance symptoms, bowel and bladder. And we definitely do see, even in that age group of like 20 to 29, certainly by 30 to 39, that these things are arising. But yeah, I don't think we have the fully accurate numbers yet. But the Leipzig group, I know also Florian's group at MGH, a number of us are trying to get that better natural history and reports from women and get that published. So more to come. Yeah.
Okay, we have another question over here. So we've talked a little bit about adults taking liraglutazone. This question is about kids. What are the known side effects? Can it be started right before or right after bone marrow transplant? I've heard that sometimes cerebral ALD keeps progressing up to 6 to 12 months after the transplant.
Well, that's a good question. The transplant part, let me think about. I mean, they're immediately after transplant, the kids are on a number of medications. So I might worry about interactions with medications, especially if they're on some kidney drugs or heart drugs. There's also some different regulations in your glucose right after transplant. So, perhaps not the first 30 days after transplant. Further out, I guess I don't see an immediate contraindication. Now, whether it's going to actually change the trajectory of a disease post-transplant, I'm not sure. I'll let you comment. Yeah.
So in the children, it's generally pretty well tolerated, and there have been kids who have taken who've taken the drug who have early stage disease, and then we also have the expanded access where we have kids with sort of more advanced disease who are on the drug as well, and they tend to tolerate it pretty well. I don't know if you've had any experience with any major adverse signals, but I can talk about the transplant piece first, if you want to go. So
And just to clarify accessibility too,
what?
Can you actually take it right now? Like an accessibility question.
Oh no, right now no. So right now the answer is no. So the answer to that is no. But I think conceptually, based on the results that we have so far, the idea is that the second a lesion appears, at least in the kids, you start taking it with the sense that the patients who don't have enhancing disease yet, it may push off the development of enhancement by a bit. And the kids with enhancing disease at baseline, this is the data that was been presented. They still tend to enhance, but their lesions don't grow or don't grow as fast. So that kind of gives you more time to get to transplant. And over the course of this 2 days, we've highlighted the issues with access and finding donors. It's a tough thing, and then getting to a center that can do it. It's really sort of a tough thing. So I think the idea for the drug right now is it can be a really nice temporizing measure. But I don't know, Patty.
Yeah, I think we need more data. And to the question, no, it's not available and it's not approved anywhere in the world for the treatment of ALD. And Minorix is trying to compile all the data from the European Nexus trial, which enrolled patients from all over. And hopefully that tells us that we can use it as a contemporizing medication. And the word is still out whether the very, very early lesions, before they become aggressive with more inflammation, which is the contrast enhancing, could or not halt right there before they turn into more active lesions with liraglutazone. In the study, we saw some of these patients doing that, not turning into a contrast enhancing lesion. I'm talking about a few kids. It's a small study. But there is some signal there that says maybe in very specific patients at very early stages, that this drug may be able to prevent the conversion to the more aggressive form of the cerebral lesions, which is the ones that we usually transplant. No? So we transplant when there is contrast enhancement in most kids. That is still out. The trial is too small to conclude that that's definitely going to be the effect. But hopefully, if the drug is approved, even to ameliorate, like decrease the velocity of growth of these lesions, that will allow us to see what is the true effect in real world, like when we are using it in children with like earlier and earlier lesions. Now we have newborn screening is allowing us to see these lesions at stages that we used to not be able to see them, and that's one of the pieces of the puzzle that we still don't know.
Hi, I'm really interested in learning more about the adult cerebral version of the disease, and specifically whether or not you see any patterns with, risk factors that might indicate that somebody is likely to develop the adult cerebral version of the disease.
Okay. Yes. Disease in adults is more complicated than in children because of the confluence of AMN together with cerebral ALD. And the path to brain lesions is different than in children, where we see more than the classic onset in the center of the white matter. We can also see the spinal cord degeneration spill into the white matter. We can also see the white matter changes move more quickly into the spinal cord. Yes, there are more patterns and there's more confluence, and it's often hard for us to distinguish whether all the symptoms are only due to brain disease or also due to spinal cord and peripheral nerve. I'm not sure I answered your question, but Sam.
No, I was just saying in response maybe to whether there are sort of any indicators of who's going to develop it. I think the only risk factor we have so far is the traumatic, so the trauma to the brain, whether it's a traumatic injury to the brain or a stroke, or anoxic injury to the brain. Those are the triggers, but we don't have any other triggers that we know of.
We have an online question first. So this is for Dr. Kemp. Someone said, I found my nephew's variant in your variant database registry, and it's marked as likely pathogenic. Do we still qualify to get the C26 lyso-PC tested? If so, would it give us additional information?
Yeah, absolutely. Short answer again, yes, does qualify. The fact that it's called likely pathogenic is because there are these guidelines from the American College of Medical Genetics, and they're very strict. So I do follow them somewhat, but not to the extent. Because if one of my doctor colleagues identifies a patient with ALD and a mutation or pathogenic variant and tells me this is the variant, I trust them, but it can be an error. So for me, it's very likely apathogenic, so that's a different likely. But we qualify it as a likely pathogenic. So if now one of my other doctor colleagues tells me I also have an ALD patient and it has the same variant, then we have two cases. And the chance that they both are wrong is for me is very, very small. So then we qualify to likely pathogenic, to pathogenic. So likely pathogenic is one case, so one ALD patient clinically affected, and pathogenic there's more than one, two or more. And the fact that if it's qualified as likely pathogenic, yes, it absolutely qualifies for the Gray Zone project. Why are you laughing at me? You want to say something, Kelly? That was not a smile.
Real question this time. This is a bit of a detour, but I mean, I'm actually impressed about the level of involvement of patients and family. And as a medical student, it's clear to me that the health paradigm has switched from paternalism to patient involvement. And one aspect that to me was missing in this ALD Connect 2025 was speaking about mental health, both for families and patients. I think this is very important, and as the person before was asking, there are like, as for the case of vitamins and proteins and amino acids, there are like right treatments and wrong treatments, also for the case of mental health. Do you think that for ALD Connect 2026, we will have a panel also for these, and also for giving advice to patients, families, and caregivers in general on how to handle this very important aspect of their life?
Yeah, very, very good suggestion. I think we're going to carry it forward.
I'm just wondering, where there are so many newborn families here, what you all advise when for toddlers, and if you have specific diet recommendations. Do you avoid whole milk? And what about when toddlers are hitting their heads a lot? Is that something to be concerned about?
So in our clinic, we don't make any specific dietary recommendations. We do get a fair amount of calls about kids, toppling over and falling out of bed and, falling down a couple of stairs. I think the way I conceptualize the risk of cerebral ALD from traumatic brain injury or even mild traumatic brain injury, these are the sorts of accidents where you'll result with a concussion or a skull fracture. Kids are low to the ground. They move at relatively low velocities. They're built to fall. They're got a lot of subcutaneous fat, and they roll around. So they're built to navigate the world that they're currently inhabiting. But something like a car crash is a different thing. Some of the guidance that I give for activities with respect to sports and pieces like that, take ALD out of it. Most child neurologists will say, you probably should avoid rugby and football and boxing, things where you literally smack your head day in and day out multiple times a day. So that's a general child neurology thing. And then you sort of map onto it risk factors for cerebral ALD due to really traumatic brain injury. So for activities, we'd say things like swimming, soccer, tennis, running, free climbing and free soloing is probably not the best thing. Falling out of a tree, anything where you meet the earth at high velocity. Those are the sorts of things that we really advise against. So I wanted to carry that into, because we have this conversation often with 8 and 9-year-olds, right? They're going to sports, they're doing that sort of thing.
I think we probably agree with those Rex Eric's offering on contact sports and so on. For diet, there's no definitive evidence suggesting that one diet is really going to be superior to another. I think it's fair to say we'd again endorse just a healthy childhood diet that is low in ultra-processed foods, has a lot of whole foods in it. I have a 9 and 11-year-old, and fighting over vegetables is sort of a lost cause. But trying to get the kids to take fruit is usually a winner, and I recommend getting as much fruit. I think the quality and variety of foods are really important for kids. The simplest way to think about childhood health is you want to avoid nutritional deficiencies with a diverse diet that's rich in whole foods. Your child will generally self-regulate for the nutritional deficiencies, that would be common. Certainly calories in America are not deficient. The things that kids do wind up sometimes deficient on would be things that probably one of the more common ones is vitamin D, only because the kind of sun exposure we evolved for is different than the kind of sun exposure we get now, and most of our vitamin D comes from the sun. That is so. In addition to a healthy diet, I recommend a multivitamin to cover the bases, and a small dose of vitamin D, I think is reasonable to add. Yeah, saturated fats are a good question. My advice is in the infant phase, I wouldn't even think about it. When kids are getting a little older, just being mindful of saturated fat intake is appropriate for general health. So once they're getting into maybe teenage years and beyond. But early life, I don't put a lot of weight on whole fat dairy products. I don't think it's probably the big driver of what we experience. Other thoughts?
Off of the first part of that question.
Yeah.
So barring, a head traumatic injury, what are some other things that, we need to be mindful of? What are the things we do need to be calling you for? For example, my son had a febrile seizure when he was 2, and that was a call to Dr. Mikowski for us. So what other, health events, shall we say, what do warrant a call to you as, a parent of young children? Keith, before you answer, can you please repeat the question?
Yeah, the question was, when should you call your, in this case, it's neurologist, unfortunately, and maybe bone marrow transplant and geneticist, but maybe to broaden it to the pediatrician too. So when would you want to call your pediatrician for something that might be related to ALD? Yeah. 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 I'll start with this, but probably the most important thing to watch for would be signs of adrenal insufficiency. I regret we don't have an endocrinologist up here with us, so adrenal insufficiency is one of the things we're screening for, and so if you're getting your regular screening visits, your child should be well positioned to know whether they're going to be, suffer some level of adrenal insufficiency during a severe illness, like a febrile illness. But nonetheless, I think any concern that your child is seriously sick or not as responsive, showing any kind of illness, your pediatrician is a good first call. Your neurologist, there aren't very many neurologic emergencies that relate to ALD. There aren't really probably any to speak of that would come out of the blue. But the fall question comes up a lot. The illness question comes up a lot, and I think early childhood, the most common one is going to be adrenal insufficiency. Yeah, thanks for the seizure question. So, or the odd behavior question. So, a lot of families will ask, "My child is doing this. Could it be cerebral ALD?" And the answer is almost always going to be if your child has had a recent brain MRI, like in the past 6 months, or even a year, or so. They're not going to have symptoms even if they have a cerebral ALD lesion, and the MRIs are timed for that reason to catch them before they have symptoms. Seizures are included. Seizures are usually a manifestation of an advanced lesion, and so if your child is having regular MRIs, and for example, the febrile seizure must have been very scary, but it's not likely to be a sign of anything ominous. It's more likely just to be they're surprisingly common in childhood. So, anyone else want to add? Yeah.
No, I think you covered. I was going to mention, one thing we have in our clinic when we have conversations with families is your child is subject to all the other stuff that other kids get, and febrile seizures are incredibly common. They look very scary, and then in the context of clearly of having ALD, they are very scary, but there's a fair amount of kids across the leukodystrophies who have had febrile seizures as kids, and it's not related to their disease. What the point that Keith brought up was, we do see seizures in the leukodystrophies in advanced disease, but as long as your kid's part of the monitoring program, we don't expect it to be related.
If I may, kind of follow up, but maybe extend a little bit. Is there an endocrinologist in the house? There isn't. And I haven't seen anybody reporting on research being done on the endocrine or on the adrenal glands. And yet, do we have any idea I mean, we keep saying the majority of the cerebral ALD children do end up needing some help with adrenal insufficiency, right? I mean, it's a predominant factor in it. I mean, is there any need for the research, or is it, I mean, it seems like if it's not tended to, that can cause a serious crisis. So with your standards of care document, didn't you put in there is it age 2 or 3, that children are going to see a pediatric endocrinologist?
Or we start right at birth. So we had this conversation when we had the breakout with some of the newborn screening families, and we'll say this in clinic: the thing that gets you in trouble in the first 2 years is adrenal insufficiency. Everyone focuses on the brain disease, but really the first 2 years, is the frequent monitoring for adrenal insufficiency.
A lot of times when you hear someone describe their child going into ALD symptoms, sounds an awful lot like adrenal crisis. The fever or the loss of, and getting seizures as well. So I think that staying the course with your endocrinologist can be one of the really important things too, because anything that goes off about that, any of those numbers or anything, are going to be a big warning sign, right? You may not even need to get to the neurologist. Maybe the endocrinologist can take care of it. Maybe we'll have one of those next year.
Are they ready?
Molly was not available.
Yeah, it's a good question. I mean, it's the not that we don't like each other, but we do consider it unfortunate that there aren't more endocrinologists in our midst. And I think it's just been it's a little bit of an artifact of history. Also, I think just the bandwidth time, and that the endocrinologists we work with they're spread thinner in other areas. But I do anticipate in the future.
We did have an endocrinologist speak last year.
Yeah, we did have an endo speak. We do have them give talks. We try to maybe at least every other year or so. So, but it's a good question, Luann.
This is for Amina. Would you share the good news about a clinical trial going on in Europe that might be of interest?
So yeah, thanks for bringing that up. We had a conversation in the women's group that so it's not enrolling currently, but the Aurora Pujols group in Spain, that hospital, I think that they recruited, I talked to her a few weeks ago, I think it was about 20 patients with adults with AMN, men and women, and they were, looking at the potential effects of a dimethyl fumarate or Tecfidera, which is a multiple sclerosis medication, and seeing how that might affect myeloneuropathy symptoms. And they are, as has been the recent trend with different sponsors and our natural history groups. They were looking at body sway, walking, et cetera. And so I think we're just trying to make sure that the investigators across the world, with whether it's natural history or sponsored studies, are looking at some of these same outcomes. So they have not even started their analysis, but they're in a phase of that. So hopefully by the meeting next year, we'll have something to report even in that small group of people.
Hi there. I have a question about thing that is discussed everywhere, artificial intelligence. So are you using it, or how are you using it nowadays at your work, and how do you see the value in near future in your work?
Bella, do you want to answer?
Hey there. I think that's an excellent question. I think I'm
Bella. I'm a researcher with the Kennedy Krieger Group, and a lot of my efforts focus on machine learning AI approaches. I think we have to be very careful nowadays. The AI is a big buzzword. There's a lot being generated, marketed around it. There are tools out there now that are absolutely fantastic, the LLM models, ChatGPT, that kind of thing. But I think the way to understand what we are using in multiple approaches and multiple studies with our artificial intelligence approaches, it is essentially a very sophisticated form of statistics. So there are approaches like clustering, where we can identify how are patients similar in their symptoms, how are they similar in how they progress. Or if we're looking at biomarkers, where we're trying to understand what can we use to predict or monitor. Some of the AI approaches are, can we create a signature out of multiple ones? Some of the machine learning approaches with imaging allow us to take these multiple data sets and help us predict how is a patient going to do, how is their disease trajectory, how is the natural history going to be, ultimately, how would they respond to certain therapies. So there are multiple efforts, and I think we have to be very excited but also conservative when it comes to the current AI landscape.
Thanks, Bella. And I just wanted to add to that you know, the methods are being refined, but like the data. So basically, you know, anybody participating in natural history, you're already contributing, and you have been contributing to that effort. You know, because like, you know, we need to feed as much data as we can. Like there are a lot of challenges with doing machine learning, you know, applying appropriate machine learning or AI, you know, models when there's in rare disease, right? Because, you know, a lot of times we're dealing with these relatively small data sets. But, you know, the important thing is that we have like a really rich profile of detailed quantitative information. So when you all are doing the walking and balance test, when you're contributing your blood samples, you know, when you're showing up to your clinic visits, like all of this is really, you know, is important and will be used as we get better with how to apply the technology.
I have a question for Bella as well. Hey, Bella, how are you? Really interesting about the predictability perspective and the power of AI. Would you be willing to give a talk on this subject next year?
Sure. I think the last time was maybe 2 years ago, where we talked about using this in imaging, but yeah, absolutely.
Thank you.
Yeah.
Thank you. My question was maybe more for the association, is to say, what's our connection to the mobility industries? You know, industries that are working on fixing mobility challenges across all disabilities. Do we have good insights into the technology? What's available? So I'll leave it at that.
It's a great question, and I really wish we had our research physical therapist at Kennedy Krieger, Jennifer Keller. She's sort of, I feel like she's the most tied in, you know, and being an expert in ALD, but also, you know, an expert with other neurologic conditions that affect kids and adults, and like working with our Movement Disorder Center at Kennedy Krieger. I can speak for Kennedy, but I think a few of us, like, we're focused on leukodystrophy centers, but we're at big academic institutions that also have focus on movement disorders like Parkinson's disease, like, you know, where they have a lot of advantages or a lot more years of research experience with it. I will say we haven't systematically explored enough. I think some of these newer technologies, you know, like, I don't know if you know, like nerve stimulation or the effects of specific types of targeted physical therapy equipment. I think somebody yesterday had asked about exoskeleton. So I think that's another aspect that, you know, as neurologists, we're not as comfortable with, but we do have our, you know, our movement disorders colleagues, our PT and rehabilitation colleagues. So maybe that's, I think we're sort of building an agenda for, for next year's meeting. So,
One of the most eye-opening moments for me was where I realized how useless I am was when we had this patient with really bad chronic pain in her feet, and I was like, yeah, I mean, that happens in AMN, this is what it is, blah, blah, blah. And our physical therapist went in there and recognized that it had to do with the posture and the positioning of the foot angle, and came up with the right side of orthosis, and the pain was gone. And it was like, oops, so we could have tried gabapentin and made them more drowsy and all that, and all it needed to do was just that level of expertise to recognize the individual muscles and tendons and stuff that they really do. So I think it's critical to have the rehab PT angle always in your care. And they are using very often neurostimulators and so on to stabilize gait, especially during walking.
Okay, I think we have time for one last question.
Kelly, let me add one thing to this. I work a lot in stroke in children and brain injury, and I do think there are two aspects of that question. One is rehabilitation, meaning a function is being lost and we're trying to still preserve it or recover it. And the other is habilitation, okay? Habilitation is, I wanna do sports, and I wanna be playing golf with my dad or whatever, and that may require an AFO that you don't wear for everything, but you habilitate someone to do what they want. And habilitation has to do with also accessing equipment for adaptive sports. So because you can remain active and doing the things that you love for much longer. So I wanted to give it and again, I agree with this, is our physiatrist and our physical therapist and our equipment clinics that really have the knowledge bulk, and we should bring them in and connect more with the disease, because you need to customize for the disease itself, and there might things that might work or not. But rehabilitation and habilitation are two different types of equipment, and they're definitely worth exploring and having discussions for what are your goals and what you're working on.
We have one final question from the audience.
No pressure. Based on everything that you've seen and heard over the last few days, what are you most excited about, or what's your biggest takeaway from the last few days?
I think it's you guys. To me, I always say we can be busy, we can be focused, we can be struggling with our own challenges and the demands of life and work. But what really keeps us understanding what we really are supposed to be doing, the reasons why, and getting the food that we need to keep going is in the room. And I'm talking about the whole room, and the ones here, the ones yesterday, the ones that couldn't make it, the ones online. That's the most meaningful thing that I think I get every year from our community.
I have an answer to this, and it's the table right behind you. It's the new people, having new, smart, interested, invested people. No, I'm serious. I think this is yeah. We're having this conversation yesterday, and no, it's really, as an ex-young person, it's a really exciting thing to see. Yeah.
All right, thank you so much.